we are absolutely delighted today to launch an absolutely brilliant book on the nursing sector in India called Who Cares? And we're delighted that we have the co-editors of the volume with us. So we have Professor Maya John, who's from the University of Delhi, and we have Professor Christa Wichterich from the University of Kassel. And we have an eminent reader as well, who we are very, very grateful for, Professor Nicola Yeates from Open University. So we will post a link to the book shortly. It's an absolutely fantastic book, and we're really looking forward to the discussions today on the book. So I will now hand over to Christa and Maya.
Yes, thank you very much. As I said already, we are very grateful that you organized this book discussion. It's a first for us because the book came out only recently. And I would like to start with my personal background, why I was so keen to produce this volume. I had been working since quite some time on social reproduction and care and on global value chains in the framework of feminist political economics. My leading question was, and still is, how is a devaluation of care work constantly reproduced? After the financial crisis 2008-9, when there was a lot of talk about resource extractivism as a development strategy in the global south to overcome the crisis, I proposed the concept of care extractivism as an analogous notion. The concept tries to capture the structures which embark on the integration of care work into national and global labor markets. These processes intensify the commodification of care work, and due to non-decent or appalling working conditions cause a depletion of the workers' bodies. Paradigmatic is the extraction of healthcare and nursing, which results in overburdened and underpaid staff, mostly women, in stigmatizing stereotypes and notorious low esteem. Additionally, transnational care extractivism has been normalized with a keen interest of the global South states in remittances as a development strategy and a keen interest of global North states in a strategy to overcome the crisis of social reproduction in the form of a shortage of healthcare personnel by importing migrant labor. Another source of inspiration was and is for me the German hospital movement. It is alive and kicking for more than 10 years and shifted from a conventional trade unionist repertoire of decent wages to the politicization of care, critique of the neoliberal hospital management, stressing that health is a common, not a commodity. The COVID pandemic and the related crisis in hospitals, for example, the shortage of healthcare staff, the lack of personal protection equipment in the beginning, and the lack of change after the emphatic applause by citizens all over the countries. All this worked as a driver for mobilization, organizing, and strikes. That made me ask, how do struggles of healthcare workers emerge? What drives them to organize and protest? And my third entry point, which I want to mention here, is from a methodological point of research. Care work and global care chains are an outstanding example for an intersectional perspective, because here gender, class, caste, a racial and an international division of labor intertwine. My research interest is to link feminist structural analysis of political economy to discourse analysis of what Guy Ling Sum and Bob Jessop call cultural political economy, and to an actor-centered analysis. Hence, I wanted the book to unveil the nexus of intersecting power relations which reflect complex realities of inequalities. And finally, when I stayed 2018-19 as a fellow in Delhi, I was keen to explore these questions and understand these perspectives in Indian society, in the economy where I had lived for a number of years. And then, fortunately, I met Maya, and here she comes in.
I really warmly thank the team at the Laws of Social Reproduction for giving us this opportunity to discuss our book, Who Cares? I also warmly thank Nicola Yeates for stepping in as the discussant. It's been very encouraging to know that you've gone through this and would be sharing your valuable inputs and feedback. I thank the audience who's joined us, and of course, my co-editor, Christa, who roped me into this very, very important work. See, initially, I'll be very honest, these are just my opening comments on, how this book for me, materialized. Um, the field of nursing labor was not initially my field of research. I would say I actually accidentally came to write on this issue and analyze it very closely. I was actually commissioned around the time of 2009-10 when the city of Delhi, the capital city, also known as the health capital of India, was witnessing a strike wave of nurses working in India, specifically Delhi's private hospital sector. So I was actually commissioned by the women's organization with which I'm working and the trade union front to, in the process of, assisting in being part of these struggles of nurses in the private sector in Delhi to, put down observations concretely. So a booklet actually materialized. And I think that's a piece of mine that Christa also came across and read when she was doing her research in Delhi in 2018-19. So I slowly began to research on this. I met Christa, in 2019. And, there was this synergy because she was obviously very closely looking at these questions. And I would see this volume, Who Cares, a product of this synergy and actually a conversation between her, me, and certain like-minded, scholars. I personally, as a researcher and as a writer, I don't necessarily adhere to the same methodological perspectives as Christa does, such as the intersectional perspective. But I guess that's what a reader can perhaps glean when going through this volume, that there are these, different methodological thrusts or emphases in the book, and hence you can see this book as a theater, where there are different dialogues taking place. With respect to, of course, the book has two parts to it. The first part, which is very much anchored in the Indian scenario, and then there's a part two, which is, of course, speaking more on the dimension of migration, international migration, and nurses' experiences, Indian nurses' experiences in the global care chains. If I just take, the first part itself, when we were writing this book and pulling it together, of course, what was happening in terms of the caring crisis, the quote unquote caring crisis across the world, and what, we can call is the coexistence of the public and private, investment in professional nursing education, that, the education that goes into making a nurse. We have both private institutions and public funded ones, as well as this coexistence of the private and public investment in healthcare services. That means in the actual hospitals. These are usually the coexistence of both public, private, and of course the larger caring crisis are attributed to, typically in a lot of literature, the neoliberal terms. There's this specific, late 20th century, early 21st century neoliberal, concept which is used to explain a lot of things in terms of social reproduction, the crisis it's going through. Now, here again, Christa and I, when we were putting this book together and we were writing the introduction, we had this discussion, and this is not just a transference of certain concepts into an Indian context to study the Indian nursing labor market. That's not actually what happens in the book, because the term neoliberal itself, it's generally used to, of course, refer to the overall goal of cost saving. So that means less state, more market, and more individual responsibilities of the citizen. Yet the use of neoliberalism as a concept for different regions of the world cannot be, equivocal. And neoliberalism is best seen in the context of the specificities of different parts of the world. So the Grand Retreat, for example, as evidenced in the global north, cannot be easily generalized, according to us, to the post-colonial economies of what we call the quote-unquote global south, where the debates on state formation have revealed that the state, and its intervention has tendentially for a long time lagged behind in matters of state welfare. So in a place like India, there's actually a long continuum in the inadequate supply of state-sponsored healthcare services, creating of professional educational opportunities, when compared to, of course, the country's exponential growth in healthcare needs. So given the widening, gap between the demand and supply of healthcare and successive, governments pushing through measures that allow for greater penetration of capital in healthcare. So that's what actually happened. The demand and supply disbalance is leading for greater penetration of private capital in India's healthcare sector and also in India's nursing education sector. Now, the much faster growth in private investment and the emergence of a very segmented private sector in healthcare represent what one would call marked specificities in the crisis of social reproduction, which not always are neatly or best captured by conceptual frames like neoliberalism that is just borrowed from global north experiences. So longer continuity of precarity in India is what the book reveals, and despite the recent growth rates in India, the reality is that the lowest quantiles of society report the least development. So, I mean, I would, quickly move on to a segment that, Christa, if I've got it right, I think you want to go into the details of how one learns certain things from the organizing of nurses in India and how one brought that dimension, struggling nurses, their organizational difficulties. How did we bring that into our reading of the situation? Christa, may I go ahead?
Yeah, sure.
Okay. So, because this is a group which is working closely on the question of social reproduction. So, of course, we're just trying to anchor our work amongst discussions you've had or you're still having. So, let me say that, the sphere of reproduction is undervalued to keep cost low. And we know this. This is a general argument amongst, many of us here on this group or writing on this theme. But what is crucial about this book, Who Cares, is that it points more precisely to the fact that one has also to see that there is a differential valuation of nursing labor. So indeed, when organizing nurses in India, for example, it's come out very clearly in the process of organizing nurses in private sector hospitals, contractual nurses in government or public funded hospitals, that, there is a differential valuation of nurses along the lines of regions, which regions they're coming from, their caste, class parameters. And by and large, if we look at care workers as a whole, not just nurses, there is a differential valuation in the case of all care workers. And, the contributors in this volume, some of whom I'm very happy to see are online, they actually reveal this differential valuation in social reproduction by pointing to the segmentation within the nursing labor market. So we have Panchali Ray's chapter in the book, which is on the hierarchy between nurses and nursing aides, in the Kolkata hospitals. We have Sneha Makkad's work on contractual nurses, on more insecure jobs with pathetic work conditions in Punjab's, government hospitals or public hospitals. We have Hemantika Basu's work or chapter on nurses and ayas. Again, they would be, nursing aides in Siliguri district's West Bengal, hospitals. We have Simi Zafar's work and Christa's chapters on scheme workers. So that's a different segment altogether of, workers employed in community health work. My own chapter highlights the prevalence of a very segmented nursing education market, feeding into a larger segmented nursing labor market. So we see segmentation not just in terms of, public private hospitals, the divide, like which is a private healthcare institution, which is a public funded one, but we also have seen that, and that's what the book brings out, and my chapter tries to show that within public funded hospitals themselves, we see a division, we see a segmentation along the lines of permanently, securely employed nurses and those who are the less secure, lower paid contractual nurses. So, let's just say that, essentially this book, this volume, when you look at its, first part in particular, we are trying to show that we cannot presume homogeneity in the category of care workers. This is especially true in the case of India, where both private and public employers use segmented labor markets to increase the wage exploitation of certain categories of care workers in particular. It's usually the lower rungs of care workers who are less protected by the country's labor laws and have less, organized, trade unions or fleeting organizations. And this influences the priorities of trade unions, actually. And many times, these organizations or trade unions compromise in terms of accruing or getting benefits for one segment of the nursing force, often at cost of the other segment of nurses. So I'll stop here and maybe, let Christa come in here if she wants to add anything further on this dimension.
Yes, as Maya said, as the book is exploring these differences in the nursing sector and in the healthcare sector, and exploring inequalities in power in terms of hierarchies and the systemic structural recklessness of the profit-oriented health market and of hospital managements, we highlighted as well the role of the states and its policies of shaping the health sector, and, as Maya mentioned already, the so-called scheme work. One of the chapters, Simi Safar's analysis of the work of Ashas and Anganwadi workers, explores the striking case of care extraction by mobilizing voluntary community work. Even after decades of schemes, the state denies them recognition as normal workers, pays them a meager honorarium or incentives only at a very irregular basis, and refuses to regularize them as public employees. So-called voluntarism seems to be the best method of cost minimization and meets the old narrative of seva, service, and sacrifice of women. I highlighted in my chapter in the volume that during the pandemic, Ashas were assigned an outstanding role in the containment of COVID-19. It is a paradoxical situation that during the corona crisis, the insensitivity and carelessness of the state increased, while on the other hand, the caregivers were celebrated as corona warriors and frontline fighters of the nation, meaning they got as much visibility and recognition as never before. The recklessness of state policies drove them to fight back against the aggravated care extraction and to increase their demands for regularization. At the end of the first part of the book, my chapter tries to summarize the reasons and power relations which cause the persistent devaluation of healthcare work and nursing in India, even so differential. The neoliberal perspective of health policies in terms of contractualization of labor, professionalization, deep hierarchization, aggravated surveillance, extension of voluntarism, and stigmatization has produced the low esteem of care work and opened even new avenues for care extraction. However, healthcare workers, not only nurses in hospitals, but scheme workers too, they fight back. The focus is on both the care recognition gap and the care pay gap. They overthrow the common perception of docility and submissiveness of women care workers. This mirrors a feminization of organization and a new type of labor struggles focusing on care work and the service sector. And they go beyond conventional trade unionist demands and politicize healthcare work while asking for higher health budget and oppose further privatization of the healthcare system. Yeah, Maya, should we go over to the transnationalization?
There were just one or two points I wanted to share about the hierarchy and segmentation and its connection to law and the state, because you have flagged a lot about that using your work on scheme workers. So if I can just elaborate specifically in terms of talking about the labor force in hospitals, which are nurses, not necessarily the quote unquote voluntary scheme workers, and how do you pitch in the state and its laws into that section of the workforce? You see, I just a few minutes back I had flagged that there is this deeply segmented nursing workforce. And those actually who are, in the permanent employment in government or what we call public sector hospitals are actually, drawing what many of us in the trade union movement identify as a premium wage. So in sharp contrast to the other segment of, similarly skilled qualified nurses, some of whom are contractual nurses in the same hospitals, we find this workforce of the permanent employed nurses drawing a much higher degree or a much higher salary, and having access to, a higher degree of employment continuity, security from arbitrary dismissal, higher, access to leaves, and many other benefits. And in this, all these benefits actually are enshrined in facilitating, in laws, and it's facilitating their greater unionization. So their unions, which is the permanently employed nurses in government hospitals, are in many ways what we'd call a manifestation of monopoly labor. That is labor that enjoys, unlike a vast sea of other, segments of the same workforce, a certain degree of protection under the important labor laws, while the same laws actually are not, extended to the other segments of nursing labor. I would just, add the second point, which is, again, important for this book in terms of what it's bringing out. And that is, there is an interlocking of inequalities, and hence, as I mentioned, there's no homogeneity in the, in care workers. So the book speaks of, for example, very crucially of education. So if you have unequal access to quality education, that is an interlocking of an inequality in terms of where you're coming from. So if you've already inherited certain inequalities in terms of your caste background, your class position, and then you don't get access to, a good nursing college. So that, results in, of course, you getting placed in a particular kind of way in the nursing labor market, usually in the lower rungs as a less paid nurse in the private sector. And of course, when you're placed like that at these different levels in a segmented nursing labor market, it's further, the structure of segmentation is further upholstered and strengthened by differential legal coverage. So, only a section or segment of nurses will have access to the protection that labor laws provide. And the outcome of this is segmented struggles. So actually a large content of the book is about, of course, this as well, that, everything is linked. Unequal access to education results in a differential entry into the labor market. And that means also differential legal coverage. Not everybody gets the same access to the protection of labor laws. And that also feeds into then very fragmented, segmented struggles of, these particular care workers we're talking about, that is nurses. So that was another, point that I wanted to draw readers' attention to, the interlocking of unequal educational opportunities with the segmented nursing labor market. I won't go into the details, perhaps in the question answer session it would come up. I just take it to the last point before we go into transnationalization or how Indian nurses are placed in the global chains. And this last point that I want to immediately emphasize is on the part of struggles, this aspect about fragmented, segmented struggles. Now, I just say that, those who end up as nurses in the private sector, which is what this book shows, that is the segment of nurses who are least protected by India's labor laws. They're actually, what we're seeing emerge is a kind of a triangulated relationship. What I'm referring to is a situation where legal protection through labor laws and union coverage, how much organization there is, are actually most, evident as you move up the nursing labor market, so into more protected, well-paid segments of nurses. And it's an inverse relationship, because as you go down the labor market, then, where actually a very vast number of nurses in the private sector, for example, are concentrated, you see the protection of law going down, and you'll see less, or what we call fleeting, trade union organization. And the vast segment of actually precariously placed private sector nurses who are not covered that much by the law are throwing up, these short-lived fragmented struggles in what, in our introduction in the book, we've talked about a typically vernacularized form of trade unionism rather than the conventional form of trade unionism based on occupational identity. Rather, you see nurses drawing on community identity, very often their Malayali identity or their Christian identity if they're Christian. So community identity, ethnicity, regional ties being used to make a union possible rather than the occupational identity. Now, vernacularity of trade union politics, which nurses' struggles in the private sector reveal, is a concept, I as a labor historian borrowed from a well-known labor historian, Sabyasachi Bhattacharya. But that's what I just wanted to bring to the table about the unionization and the fragmented struggles, which are also linked to, the way in which the labor market is so segmented, and there is this differential valuation of nurses. And hence, I would stop at this point, and I would hand over to Christa, who wants to talk about the transnationalization aspect, and then I can pitch in.
Yes, as already said, the second part of the book deals with Indian nurses abroad who went abroad as migrant nurses, and migration of nurses is a significant part of global care change, as described by Nicola Yeates. And it is an ambivalent process with gains and high financial and social costs. And the chapters on Malayali nurses abroad focus very much on the agency of the nurses. And I'm happy about this in terms of their motivation to migrate, for example, for financing their dowry or repayment of their debt, for remittances to their parents, and in terms of their decision to circular migration or settlement. These Malayali nurses benefit a lot from, and they co-construct networks, mostly Catholic networks, which function as their social capital and safety net abroad. In Germany, in the 1960s and 70s, Malayali nurses were recruited in the context of the so-called guest workers model, meaning the idea was to recruit labor force in times of shortage and send them back like a commodity when no more needed. While in the hospitals, the nurses performed nursing as a very gendered labor. At home, the gender division of labor was broken up because their husbands had to take care of the kids, which was at that time exceptional in Germany and even more so in Kerala. However, a number of nurses left their small kids or babies with their family in Kerala and returned to the receiving country, and they suffered a lot from the separation. Those children who later joined the mother in the receiving country were subjugated to a tension between upkeeping Malayali culture, norms, and family bonds in the private sphere, and gaining a foreign identity in the public sphere. Bonds to the transnational family, in particular to the parents, are nowadays nurtured by daily video calls or sometimes several WhatsApp calls per day, which make for a strange tension between distance, geographical distance, and emotional closeness. What is coming out of the chapters in the second part of the book is that the nurses working abroad are not victims, but agents of their life. Maya, do you want to add on?
Just one point, and this is, of course, with respect to, apart from the agency aspect or dimension to this migration, I would just add that the chapters in the second part of the book, which are on nurses who've migrated to the West, there is, of course, another very important side to this story, and which is that the process of migration of nurses abroad is an ambivalent process. And this is because, the skill drain, or what many call the brain drain of, these nurses who have been actually products of nursing education provided in India, when they are moving out of the country and their skill is then, part of another economy, it becomes, a drain for the sender country, which is very often a poorer country with huge health needs of its own, healthcare needs of its own. And of course, it's an ambivalent process because, the skill drain that's happening is even more, a problem if, that particular nurse who's migrated has been a product of education, nursing education provided in a public sector or a public funding nursing institution. So it's like, society of the sender country, in this case India, has actually spent for their education, but that particular nurse's education, skills are no longer something that society can tap. So even if these nurses are, sending remittances back home to their home country, the paucity or extreme shortage of nurses, and it's a projection, it's a conservative one according to me, some 2 million nurses are shortage in India, but I think it's a much larger number. So the paucity of nurses in India continues to deepen the very acute crisis of social reproduction already brewing for the masses in India, which is the sending country. So I would actually just, conclude with saying that from my end that, if we look at the new trends, the new questions which are emerging with this transnationalization of care work, particularly through nurses and their positioning in the global care chains, I feel that this, the tension between the public-private divide in professional education, nursing education, fueling an aspiration for migration. The two realms in particular are going to determine future migration patterns. Number one, who is going to bear the cost of skilling, a private institution or a government institution for nursing education? And two, the general demand for better healthcare. So I think these two dimensions or realms, their interaction is really going to shape future migration patterns of Indian nurses abroad. Thank you.
Yeah, and we are looking very much forward to the discussion here about this dilemma in this manifold interest in migration of Indian nurses, and between the dire need in India itself that qualified nurses work in the country and won't leave the country. So what does this mean for recruitment and for sending nurses for Indian abroad, from India abroad?
Great. Thank you so much, Maya and Christa, for very concise overview of really quite a rich set of chapters, in the book. So now I hand over to Nicola Yeates for her reading of the book. Nicola.
Thank you, Prabha. Thank you. Well, thank you so much for inviting me, and it feels such an honour and privilege to be able to come here, join you all here today, and give some thoughts about this wonderful book. So I really, first of all, want to congratulate Maya and Christa for pulling together such a wonderful, fascinating and powerful evidence evidence base around the complexities of the nursing workforce in all its shapes and guises within the wider political economy of health workers, national, India, and global as well. So it's a real contribution to this literature. And in fact, it's a remarkable book in many ways. One of the things I really liked about this book, apart from the beautiful words and the beautiful analysis, was the beautiful images, which the editors decided to include within the book. They're absolutely fantastic. So it's thoroughly recommended on those grounds. And I really commend the author, the editors, Christa and Maya, for actually including those, as well as the transcripts of interviews with Indian health workers as well within the book. That makes this book really special, I think, and it's really great to see this kind of coexistence, or these different voices, academic, migrant workers, Indian health workers who stayed in the country, and others besides, actually juxtaposed in this way. I mean, I think Maya and Christa both brought through, the kind of the comprehensiveness of the book, and actually, the really important point that, that Northern theory cannot be just kind of transplanted into global Southern context, including India, as different development trajectories, and that must make a difference, as it does, for both the politics of any particular issue, but also the ways in which we analyse it, in which we understand it. So that really comes to the fore in this book. And just listening to Maya in particular kind of talk about the differentiations, the heterogeneity, the nuances, the intersectionalities. Really, all of these things really do come through very, very powerfully within the book, and it's such a strong argument. So yeah, I mean, so I would definitely, I wasn't invited on to do a sales pitch, but if anybody hasn't yet got hold of the book, then I really thoroughly recommend it. It's very reasonably priced, I understand, and it's just contains such a fascinating array of evidence, and really kind of gets into the complexities and some wonderful kind of insights that really come through within the book. So I think one of the I mean, I am, yeah, so the questions that the book asks are absolutely spot on. The book as a whole addresses the really important questions about who gains from the current mode of production of nurses, of health workers, whether within India, whether outside of India, how those rewards, risks and losses are distributed among the different actors within these transnational and national structures. How does gender intersect with other axes of social division, and and how are social relations in the meantime transformed through these very processes? So all of these come through very richly in the course of the book, and I learned lots. I mean, I'm not an expert on Indian health workforces, I must say, but I learned so much about the sector as a whole, about the current dynamics, the politics actually of the topic that the book addresses, and some absolutely wonderful nuggets. And I just want to share one. I think this is one that came up that you brought into your chapter, Christa, and for me this absolutely encapsulates what so much of the book is about, which is the example that you brought in of how in Delhi, I think it was during the pandemic, medics, doctors who were infected with COVID were put up in 5-star hotels to protect them, and nurses were shoved into communal, overcrowded, accommodation of some kind. And that just, to me, absolutely epitomizes so clearly and so well the differential value assigned to lives, within the health workforce. So there's lots in there. I have a couple of questions. Actually, I have 5 questions, which are intended to, kind of spur discussion and kind of induce dialogue, really. And one is, the first one is this really exciting concept of the voluntary labour regime. I was really taken by this. So it comes in the context of your treatment of informalization, the increasing reliance on kind of informality and informal relations of production, which has been noted actually, which I know exists in other parts of the world as well, increasingly, which is really interesting, which is why it caught my eye, of something that's so preponderant within the Indian concept. But I'm left wondering, I'm left wondering, wanting to know more about it. So perhaps this is the forum in which to have that discussion. So I'm wondering, is it the same as decommodification? I wasn't sure. What's its relationship to social reproduction more generally? What's its relationship to commodification? Is it decommodification? Is it recommodification? I wonder if maybe you could start to spell out, more fully the relationship between the voluntary labour regime that you're pointing out in respect of the nurse workforce in India and commodifying processes. Second point is around care extractivism, or second question really is around care extractivism. So the book very powerfully uses that to analyse, the mode of extraction of care labour, particularly of providing physical care, I think. But I just kind of wondering how it relates to other concepts, for example. I mean, I was wondering, is it different from, is it the same as the global care chain concept and the idea of the global nursing care chain that's been discussion? Is it the same if it's a mode of accumulation of power, of resources? I'm just wondering, what's the value to be gained by using it in preference to other terms, like, for example, super exploitation? Not just exploitation, but super exploitation. In particular, it's been so strong within world systems theory, for example, and elsewhere. A third question is about neoliberalism. So at times, it seemed as though neoliberalism is brought in to explain everything that's going on. Whereas I'm sure, and just listening to both of you speak now, that of course, far from using it in a reductionist way, that there are kind of varieties of neoliberalism happening around the world. Of course, we know that, but I'm just kind of wondering how, even within India, that neoliberalism touches down differentially between different states. Okay, because as I understand it, health worker, healthcare governance isn't just a federal matter, it's also a state matter as well. So I'm guessing we might see some variations in terms of how that neoliberalism or that ideology actually manifests and touches down in different parts of India. My fourth question is about COVID-19, and I was really delighted to see that this was the entry point for the book. And of course, COVID-19 has everything in it, as such, and just speaks so powerfully to many things. That's a really welcome focus, but it's also really welcome that you didn't address it in every single chapter, because there is a tendency, I think, sometimes to do that, you know, to kind of force it in even where it doesn't naturally fit. So I really welcomed that. And it chimes a lot with the recent research. I mean, I had a project recently on how migrant healthcare workers have fared during the pandemic. So a lot of what you were saying, the authors were saying, really resonated with that. So my question arising from that is actually segues very neatly into the fifth question, which is that it's about the implications for governance, for policy, for politics of your analysis. So if you, you know, make some recommendations or highlight maybe 3 key points that you would like, you know, kind of policy officials or advocates to take away with them from this volume, I was just curious to know what they would be. Thank you.
Great, wonderful. Thanks, Nicola. Those are really useful. So Maya and Christa, you know, please do feel free to respond to Nicola's comments, and then we can open it up for Q&A.
Yeah, I think I would like to start with the question on voluntary labor regimes. We have this voluntary work of women, I think, in the service sector everywhere. And it's, of course, helping each state and each society to facilitate social reproduction without much costs. And in the case of India, I think we cannot transfer the Western notion of informalization of a process that it sounds like it's a process of formal work becoming more informal. This is not the case in the global South, because this voluntary labor regime in the communities, mobilized by schemes, is not, and this holds true as well for the notion of decommunication. This work has never been formal. It has never been commodified. So it is introduced starting from community life in which certain forms of collective caring for each other were working as such. And now a state comes in with schemes and says it promotes this voluntary work by giving a honorarium for it and paying incentives like this. This is a start of a commodification process, and actually the women who are very keen to do this kind of voluntary work, they hope that they will be employed, will become public employees, and they will get paid a normal wage and will be paid regularly. But this has not happened since the 1970s. In the 1970s, these schemes came into existence, and most of the schemes actually were financed by foreign aid agencies. So it's really a cost-saving strategy introduced by the state. And the women are always told, you can easily do this. It doesn't need much training. They get a little bit of training, but not very much. And it's just an extension of what you are doing at home in the family and for the kids. And so it's an extension of the service. This is how this definition of voluntarism comes in. But it has been so useful for the state, and there are a number of studies which show that it was altogether, it was very successful work in terms, for example, of child nutrition and health of the mother and so on. So it's really a form of having cheap labor on the community level. Perhaps I continue with the second point, and Maya, then you take over. The second point was care extractivism. I'm very often asked the same question: why did you propose this, and why do you suggest this? Is exploitation not enough? As I said in the beginning, it came up as an analogy to resource extractivism, and it makes very clear that care capacities, skills, care energies, which always includes some emotional components, that they are a resource. They are a very important resource for society and for social reproduction and for the economy and the market. So I thought, and the fact that I'm challenged again and again, why this new notion, I feel affirmed that it is really making a point of attention. People are thinking about what is happening in a systemic way there with care capacities as a resource in society. And altogether, after working now with it for about 10 years, I am happy and I find it a useful and constructive concept. Maya, do you want to take over?
Yeah. So since Christa has taken two questions, I'll quickly give my response to those two as well. So when you are referring, Nicola, to voluntary labor regimes, obviously you're speaking very specifically about what in India is known as the ASHA workers and Anganwadi workers. So basically a voluntary community health workers scheme, which has been run under what is known as the ICDS, so Integrated Child Development Services program of the Indian government. Now, a quick point here is that, again, just the kind of brief history that Christa traced for you a few minutes back in response to your question, you'll see that, number one, this so-called voluntary labor force of ASHA workers, Anganwadi workers, is the term voluntary is actually the state's language. They don't see themselves as voluntary. They actually see themselves as workers. And that's been their fundamental battle for the last 20, 30 years as they've tried to organize themselves and protest on the street. So it's the state's language, and this is also part of the larger, growing and entrenching informalization that we're seeing in the Indian context, where the state is steadily withdrawing from regulating employer-employee relations. So it will obviously tag even such kind of work, which is concrete work that women are doing, as non-work. So of course there is that. What I'd also like to add here, so there's of course a longer history to this entire process of relegating this work by ASHA workers and Anganwadi workers as non-work in a way, which goes beyond the neoliberal turn. So there's a longer history in India of the state, the Indian state actually using cheap labor, and it's not a coincidence that these are mostly middling and lower caste women. These are women who are poor women in terms of their class position. They're working class women themselves. So it's a long history of the Indian state using or tapping cheap labor to get a lot of work done a lot of community, society work done, care work done, of the laboring poor. You see, these community health workers are actually put to services of laboring poor. So they're actually assigned to slum areas. They're actually assigned to working class neighborhoods. And so a larger concern, I think, of anyone who's researching on this from the point of view of also activism and how to challenge this kind of regime of work and informalization, is that this is not good either for the worker, who's being called voluntary, person, a voluntary scheme worker. It's actually not good for the worker, this arrangement, these kind of schemes, and neither is it good for the recipients, of this kind of, community health work. That's because it's usually the laboring poor. I'll just give you one example to establish this. Recently, the government of India in 2020, 2021 said that the Anganwadi workers are going to teach laboring poor children between the age 3 to 6. They're going to teach them the basic, early childhood education. So the rich children in India go to these very fancy play schools and learn the alphabet. The poorest children will be taught by untrained, overworked Anganwadi workers in slum areas who actually are not capable of doing this and teaching you the letters, right, or basic mathematics. So it's like this it's neither good for the workers because the state is denying them actually an identity of worker, neither is it good for the recipients, on the other side. So that was just my response to your question. About care extractivism, I would, of course, pitch it as, there is one important element sometimes missing in the use of the concept. I would see it more, and that is work. So it's actually care work extractivism that is happening. And I would, because, it's not, we can't just look at this domain of work through, the lens of emotions, because the workers are not, emotionally attached. Let's be very clear, like that pressure may be there from society on them, but they are seeing this very much as a waged relationship. So it's actually care work extractivism. And I would pitch it at another level as well by saying that, for many of us, it's, looking at this domain of work and this kind of, relations of work. The point is that in a country like India, there is so much exploitation happening, especially I would actually, and I use the term more than care work extractivism, I use the work over exploitation or super exploitation, because I see that there's a level of the workforce which is, as I keep saying, better protected, better placed, and then there's lower rungs, which is a sea of care workers, like less qualified nurses, etc., in the private sector, who are paid less and more exploited. And the agenda is to bring down the average rate of exploitation. So wherever there is differential rate of exploitation, we have to, of course, identify that and then say that, actually the need of the hour is a politics which pushes down this, divide, which reduces the divide, and so brings down the average rate of exploitation. So, that would be my additional observation. Can I take it to the third point of your question, the third question on neoliberalism and its connection to federalism in India? Right. So I'm glad you brought that question up, because I do touch upon it in my own chapter, because when I was dealing with the education sector in India and nursing education, I'd shown that, and even the kind of hospitals we have in India, you see in India's federal structure, which is many of us call a quasi-federal structure, not a real structure of federalism. We have states in different Indian states which are at different levels of development or growth, economic growth. So the central government or the federal government, with its, of course, much larger resources, runs a couple of its own hospitals, when we're talking specifically of nurses. So these central government hospitals are the best. They're the best because, of course, the resources channelized through the federal government are much, in terms of quantity, much more. And so these, a few hospitals have the best infrastructure and the best doctors, etc. And of course, they offer better pay packages and security. Then you have a couple of states in India, which I would say Delhi, for example. Delhi is a state. Delhi and a few others, which again are hubs of a lot of economic growth, higher levels of growth. So the state government hospitals of Delhi, for example, are almost at par almost at par, not all of them, almost at par with the central government or federal government hospitals, but there are a large number of states in India's federal structure which are, which are lagging. So I'll give you an example. For example, Bihar is one state in eastern India. We have some of the some of the states which have a vast amount of tribal population. Jharkhand is one such state. So you see that uneven growth resulting in those state governments not being able to channelize the same amount of resources to run, a healthcare, public funded healthcare sector of the same level as the federal government or even a place like Delhi. So I would say that, of course, this regional disparity is very much playing itself out in the nursing labor market and in, differential access to healthcare, quality healthcare. Christa, maybe you could come in on any of the other questions.
Yes, I still think, just to add on to this, I still think that we can talk about neoliberalism in India, because the Indian state, after independence from the colonial regime, claimed so much to have a mixed economy and a strong public sector. And now it is withdrawing more and more from this public sector and really pushing and firing privatization all through. Yeah, your fourth question related to COVID, actually a number of the chapters were conceptualized and partly written before COVID started. And then we left it like this, and as only, a few refer very much to COVID, like my own chapter. I thought, yes, that gives enough inspiration to make further links when more research on this, in particular, COVID situation, which made so much visible, which had been there before, but in this crisis situation, the working conditions of nurses became more visible, and a greater public reacted to it. Implications for governance, these was your last question. I will start, and Maya definitely will go on. This is, of course, linked to what I said just now, the withdrawal of the Indian state from the public sector. And this notorious, for example, notoriously low health budget in India. So one of the first demands would be to conceptualize the health sector completely different and much more from a caring perspective, from a caring state perspective. Comparing it to other budgets for other sectors, it has to be valued much more. And only if this is done, this higher valuation can trickle down to the level of the healthcare staff, and in particular to the level of nurses and, for example, scheme workers. So that the Indian state increasingly, for example, privatizes education of nurses is one indicator for this, and an indicator of a neoliberal gestus to transfer the costs of education, which should be covered by the state itself, that these costs are transferred to the individual nurse, who has to pay a lot for the education, for the most of the time, good education in India, if I compare it to European nurses' education, but all of them get indebted, and as a result of in this indebtedness, they have to work in private hospitals under a kind of bondage and really super exploitation, and they are forced in the end to migrate in order to be able to repay their debt. So these are circles included in the present system, which have to, which have to be taken back in order to set up a better public sector, go back to a public sector which has to be democratically controlled, so that the funds are really distributed to overcome the inequalities which are existing and always reproduced through this system.
Okay, so I mean, being a labor historian and also being located in India makes me, of course, see certain kinds of, questions or concepts which arise from debates and analysis of situations in the West. With a bit more of skepticism. So the concept of neoliberalism, and this is something Christa and I have talked about, I'm skeptical about the blanket use of the term neoliberalism in the context of India or the wider global South, because you see, it assumes that things were, they were better, they were good prior to the current situation. Now, in a place like India, if we look at the way in which, the health sector has functioned, there is actually, of course, I'm not saying that there hasn't been, the crisis hasn't become more acute. Of course, the crisis in healthcare has become more acute in present times. But I would say people like, a person like me situated in India is also emphasizing a longer continuum of unevenness in the state's presence and investment in the sector healthcare. So why do I say this? For example, the voluntary scheme workers, who are also part of our book's analysis, have been around since the 1970s. They're not specific to the 21st century. Similarly, I know of, from generations before mine, laughing and talking about how, you could walk into very often a clinic and it would be a master's in political science, a person who's a master's in political science distributing medicine. So quacks, and this would be sometimes in cities. If you go into the interiors, we have indigenous, or tribal populations, it's even worse. I mean, there's no hospital in 300 kilometers, and even today, if you go to those areas, it's a similar situation. So I'm just seeing a longer continuum of the state being very, very absent, in healthcare, facilities and bringing them up, rather than just showing a departure or a break in current times. I'm saying it's become more acute, but it's got a longer history to it. And I think that perspective is important for us to bring in, because, then we can also talk in terms of future strategies, in a similar manner, and it also shapes the way in which we're looking at a future. So of course, the future is talking about much more public funding for healthcare. It's and it's a demand which says that, it can't just go back to some previous stage of 10, 20 years. We've been asking for a much, much higher budget, much, much higher channeling of resources for a long time, and it's increasing. The amount required is increasing, so that would be something that we would be pushing for if we see a longer continuum. And we'd also argue that this, because the state has been relatively so absent in post-colonial economies, in the global South, we would also end up, arguing that there are other kinds of struggles which are needed at this time, and we then start going beyond the neoliberal, context or concept to argue something like this, that there is a need to work towards struggles which supplement each other. That is, there is need to develop a synergy which, a synergy which does not just resist the precarity and the oppressive conditions that exist in the healthcare sector for workers, but also work towards creating transformative conditions. Put simply, I'm basically saying in a country like India, witnessing the lack of adequate public investment in healthcare infrastructure and nursing education for many, many decades, it means that there's been a rising out-of-pocket expenditure for a vast number of poor people. And in this context of a crisis for such a large majority in our country, nurses' struggles, need to connect and engage with, in a synergistic way, with the demands and people's movements for better public healthcare delivery. So ultimately, more public funded hospitals is a crucial demand, which translates into more expansive quality public healthcare, as well as more jobs for qualified healthcare, nurses. So more educations, public funded education institutions, more hospitals, and hence more nurses being created, more doctors being created, means better healthcare for India's masses. So that dialogue and that synergy needs to be developed, and not just talking about certain kinds of demands in a neoliberal context, but seeing a continuum in pushing for more concrete organic connections between different domains of struggles needed.
Fantastic. Thank you so much, Maya, Christa, and Nicola. That was really a very rich and engaging conversation. So I want to open up our event to other attendees, and just to see if others have any questions for all of you. Please to raise your hands, or just type in your questions.
I wonder whether one or the other of the authors of the book is here and would perhaps like to add something on.
I think I saw Himantika.
Yes, hello.
Hi, yes, go ahead.
Yeah, it has been a wonderful learning experience. I just want to share, how I've been a part of this journey and of this book. And it was a long drawn project. Actually, it suffered a lot of delays, but I want to really thank the editors, Christa and Maya, for putting all of us together. And it's a very relevant topic, I think, especially in this phase of post-COVID health situation in the country. And yes, and a sector, the healthcare sector, the care sector as a whole, the situation of nurses, especially in the private healthcare sector, a lot of segmentation, a lot of fragmented understanding of this entire group of workers who still are ongoingly suffering from lack of recognition, a lot of fragmentation in terms of lack of unionization. So I think it's a wonderful attempt, and it has been a wonderful journey to be a part of this project. So yeah, I don't have any questions as such. Thank you so much.
Thanks. So I don't know, Urmila, do you want to say anything? Otherwise, there's a question from Mansingh. So why don't you go ahead, Mansingh? Just put your question out there.
Good evening to all. First of all, I should say thanks to Maya ma'am and Christa ma'am to coming back with this book, where they have nicely, as they mentioned, about the contractual workers and disparity among the regular and the contractual ones, and especially about the nursing issues. Basically, I am a nurse working in a tertiary care hospital, and I have a privilege to be the permanent one, so I don't, in comparison, I don't have much issues. But one thing I want to raise, which always coming in my mind, is that all the government documents always say there is the shortage of the nurses. Maybe Maya ma'am has come up with these documents also, and a lot of time I meet her and discuss this. But if we see in anywhere, there is a lot of, whenever there is a vacancy come, there is a lot of number of applications are coming. and there's a lot of migration of the nurses are going on from India to abroad, majority of the countries. So I want to have a note on this. Is it true that there is a shortage of nurses, or there is a not organized the properly? This is my question.
Wonderful. Thank you, Mansingh. I think there's another question also from Anurag Babu, who is asking about how do GCCs pan out in the Indian context, and if there are any differences in terms of caste, class, and regional origin, and then the position of recruitment agencies and other intermediaries. And then I think I wanted to add one question following up, tagging it with Mansingh's question, which is that there is a lot of, with India being the, the president of the G20 process this year, and renewed focus on the care economy and its potential to generate, millions of jobs and so on. Clearly care is on the macroeconomic agenda. So I just wondered, if you had any responses to, that kind of the centering of the care question in such high profile, policy and political domains at an international level, and what this means for, the nursing sector in particular. Go ahead. Either of you can respond.
I think, Christa, you should come in and talk about those agreements between the German government and, Kerala.
Yeah,
Kerala.
first I would like to refer to the WHO code of recruitment, which was set up with a list of countries which suffer from a shortage of nurses, and from these countries should not be recruited. This list was set up in 2010, and India was there. And in 2021, it was revised, and India was no more there. And I tried actually to find out how India disappeared from this list, but till now I couldn't find out. So when India was no more on the list, for example, the German government immediately stepped in and entered into a memorandum of understanding with the Kerala's government. And so it's now a government contract called Triple Win, which gives the impressions every side's win in equal terms. And after this contract has been signed, now I learned that in March, 200 nurses from Kerala will come to Germany, and thousands sent their applications. So there is a high demand for migration, but this fact of shortage of nurses in India is not discussed, I think, at all anymore. So the figures we have, the figures are perhaps not the latest figures based on the latest census, but the figures we have show that there is a tremendous shortage all over India, perhaps not in Kerala itself, but all over India.
To add to the, thank you, Mansingh, for joining us. Christa and others, if I can just introduce Mansingh. He is a nurse working with All India Institute of Medical Sciences, AIIMS, and he has been a wonderful, contact and somebody who has been, vocal and participating in nurses' struggles. And he's part of this initiative where there is a lot of concern about how do nurses' movements understand the larger public demand for better health care. That connection, that synergy between struggling nurses and the masses is important. So thank you for joining us, Mansingh. I definitely would say that there is a shortage. So it's actually a problem which is both. There is a shortage of nurses actually in the country, and there is also migration. It's not because there is external migration that we have a shortage. And why am I saying this? Even if the few hundred nurses who are leaving the country for greener pastures abroad, even if they were to stay back in India, we would still be short. Because just look at the way in which our hospitals in cities currently are, and then also look at the lack of hospitals where they should be in so many parts of the country. If you start with the cities, take any tier 1 or tier 2 city, go to a hospital. Let's take the example of a government or public funded hospital in a city. There's a shortage of doctors, there's a shortage of nurses, there's a shortage of beds, and hence there is so much footfall that people are like just generally getting angry. Patients and their attendants are getting angry with the hospital system because it's like, oh, they're neglecting us. And why are they neglecting us? Because there are more patients in every ward than there are actually nurses and doctors available. So of course, in the cities, that problem exists in any general average hospital, which is a government one, which you walk into. If you go into the interiors, I mean, seriously, I mean, just going on a highway, driving down a highway, if you were to have an accident, you would probably die before you reach you reach a hospital, because there is literally no hospital for 200-300 kilometers. So of course that means the healthcare needs are continuously growing, and our system is not producing. The Indian economy, the education market, is such that it's not producing enough nurses and other specialists. With respect to the question, Christa, can you see the questions in the chat box? There's one.
No.
There's one from Anurag Basu. Sorry, Babu. I don't understand the first question because I don't know the full form. GCC. How do GCCs pan out in the Indian context? Are there any differences in terms of
global care chains?
Oh, okay. Global care chains. Okay, got it. So can you see the question now, Christa? It's in the chat box.
Yeah, now I got it.
It's a subsuting.
Yeah. Actually, what we are talking about is this increasing and intensified commodification of this process. It's not just that more nurses want to leave the country and are pushed to leave the country, but the agencies which come up in India and, for example, in the West, are mushrooming like anything. And this means there are so many people coming in, making money from this process of recruiting, of placement of nurses. And this actually is something which is presently not at all regulated, and what would be one of the demands to regulate this. Maya, can you answer to the question with regard to differences in terms of caste, class, and in the global care chains? What I can contribute is that I'm doing presently interviews with a generation of nurses who came, Indian nurses who came to Germany in the past 10 years. And if they can if I compare them to the first generation who came in the 1960s, then I see that they are coming very much from middle classes, and they, when staying, for example, in Germany and earning their money as a nurse, they don't have many financial obligations towards their family. Earlier, they had a number of brothers and sisters, and they were very keen, and in the end, they were very proud that they made the education of all these brothers and sisters possible with the one job as nurse in Germany. This has changed, and I have the feeling there is a class change as well. in the first generation, they came mostly from a poor background and the parents were in agriculture. And now, yeah, it's middle classes, and they say it's a kind of culture of migration as well in Kerala, which drives them to greener pastures, and they are looking for a better life. That is their key motivation.
Just a quick point. Thank you for your question, Anurag. I would say that looking at your question on global care chains, I would say that, let's look at it from two dimensions or two angles. So in the larger macro level, at the international level of migration, the dimension which is, very important to understand is, and what we try to bring out in the book, is the fact that, you have these, better off, wealthier countries, right, or regions, which are not wanting to spend on the skilling part that would create nursing labor. So they then, tap the, less affluent countries, such as in the global south, who have actually, made a certain amount of investment and have, these qualified nurses, and you're actually tapping them for their skilled labor, right, and saving on your own cost for skilling. So of course there is the paradigm or dimension here to look at closely is affluent country and less affluent country, and how are they connected in the global care chain. It's obviously for the less affluent country a skill drain, because your society, your political economy has trained someone, but no longer is that skill available for your own use. Which is why in terms of policy level, Prabha, your question, it has led to these kind of, negotiations and checks and balances that, you can't recruit from certain countries, but then you can see how, global capital, of course, very easily functions in a way in which, it suddenly overnight can change those checks and balances. And again, you slide into a situation of an affluent country easily, draining a less affluent country of its skilled, workforce. Now, if you look at the other dimension of your question, which is the question of caste, class, and region, I think those parameters are more, you can trace it more closely how these function and shape who is becoming a nurse and where does the nurse end up. If you're looking, particularly at that process of when a person decides to study to become a nurse, so the regional dimension. So we know in India, there are certain regions in India, so certain southern states and a few northern states, which are hotbeds for, nursing colleges, right? So these would be states like Kerala, Karnataka, down south, and up north, it is Delhi, Punjab, Haryana, Rajasthan. So there is an uneven development of nursing education in the country, with some states, some regions being, centers of increasingly, of course, private nursing education, right? So, let's say these families, many of whom are middle class families or poorer families, use their household savings and they invest in nursing education of a child in usually these hotbeds or hotspots. And then starts this journey of, if you're in a private college, the whole burden of paying back your education loan. So you pick up any job in the nursing sector available in the country. And of course, if you want to, factor in the question of caste, what I and others have been able to trace in the context of how people are becoming nurses and how they're entering the, Indian nursing labor market, we've seen that those who do the shorter 3.5-year diploma nursing course are actually coming from poorer backgrounds and lower caste groups. Those who are opting for the 4-year BSc nursing degree are generally coming from higher caste groups, better off, families economically speaking. So, you're seeing that kind of division unfold and shaping the Indian nursing labor market. So that would be my response. Thank you.
There's one more question I see.
Yeah, go ahead, Shitapa.
Wonderful presentation, and I think Maya has responded to part of my question that I was going to ask. I was just curious to maybe, it would be really nice if you can expand on what you just spoke. I was thinking that, when you're talking about the shortage of nurses in a country, are we also talking about kind of a mindset and a stereotype that we have. For example, we know that, I mean, we can see nurses from Kerala and from Northeast in every nook and corner of the country. So does that mean that there is some kind of an acceptance of, of nurses from this region? And I'm talking here, and if you go to any private hospitals, or private nursing homes, you will see only nurses from Kerala and Northeast. But and what about the rest then? What happens to the rest? And also in particular, what percentage of Muslim men and women do get into this sector? I was just thinking that, is it a mindset that we think that only, like nurses from Northeast or Kerala would be better nurses and be able to provide better services to the patients? And hence there is so much of emphasis in these states, and vis-a-vis the rest. Just if you could comment on that. Yeah, thank you.
In the book was the focus very much on Malayali nurses abroad. And it has been, I think, in the literature up to now very much. I have been last week to the German embassy, and apart from this Kerala Memorandum of Understanding, Punjab and Telangana propose such a kind of memorandum of understanding, so that more nurses could migrate to the West. So there will definitely be some diversification in future. What I see clearly as a change over time, that 50 years back, it was very, very much family survival strategy when they migrated. And now it has become more individualized, and it is more a kind of autonomous migration. And yes, Maya, do you want to continue?
I'm just trying to quickly gather my thoughts.
Yeah.
I would just say that Sutapa, so you seem to ask a bunch of questions, 3 or 4 questions. See, I would just take on the main one, the one that you asked about mindsets. See, I think mindsets is not an autonomous, arena. Mindset of who you're going to hire in your hospital links up to, the structural, realities. So if, as I said, if in certain regions or states of the country, there are less nursing education institutions, so there are less nurses coming out of that area. So obviously there will be hiring from, elsewhere, and that will be, for example, even in a place like nurses coming in, you're saying that we're Keralites, so of course they will be hired quickly. So there is, I think there's an enmeshed, it's a very enmeshed relationship between mindsets of hospital managements, employers, and the actual nature of the nursing labor market and nursing education market. In terms of some interesting changes that we are seeing, there are, of course, changes in terms of which regions are now producing nurses, qualified nurses. So in the last few years, and I'm not sure Mansingh ji is still online, but I actually got this observation from Mansingh as a nurse, and he's from Rajasthan, and he had, shared this, and I'd followed it up and looked it up, that, recently in the last few years, because of, as I told you, the premium wage and more protected conditions of work that the federal government hospitals like AIIMS, Ram Manohar Lohia, etc. offer, even, men from lower middle class and middle class families, Muslim, Hindu, different communities are aspiring because it's a government job, a protected government job and good salary. So what's happened that in places like, for example, if you just look at North India, Haryana, Rajasthan, Delhi NCR have become like areas of coaching institutes. So, what's happening is that, they are going for this intense coaching to crack either examinations for hospitals abroad, and the language exams, or they are going for coaching institutions in these states and opting for these cracking the exams for AIMS, Safdarjung, Ram Manohar Lohia Hospital. And what is happening is that the profile is that male nurses are coming, and it's actually creating a lot of discontent within trade unions, which have generally been led by women nurses for a long time. So there is interesting conflicts breaking out, and there is this changing composition, regional composition of nurses now. It's not just women who have been seen in the last few years concentrated in this work. So I would answer your questions like that. So the structural nature and changes are shaping who's getting hired and placed where.
Wonderful. So I think we are over time, and I know there is one more question on the methodological aspects of the study, but I think that might be best answered by actually reading the book, I think. And you will see, because I do think there is a unique sort of methodology to bringing together these very varied voices and bringing it within an overarching narrative that is making a contribution to the field. So I'd like to now thank all of you. Thank Maya and Christa for an amazing book. Congratulations again, and to Nicola for your very generous and constructive reading of the book. And thank you very much. I think for us within the Laws of Social Reproduction Project, we are looking at quite different areas of reproductive labor, and we can already see the differences between something like, say, nursing and potentially teaching vis-a-vis some of the most stigmatized occupations that we're looking at, as well as more unpaid forms of work, and seeing sort of connections between all of this. So it's been very productive for us. Thank you very much, and please all of you.
Thank you very much for organizing this debate.
Yeah, it was very, very, very fruitful, and we were very happy to do it because the book just came out in late January, and this is actually for us, Christa, kind of a book launch, not so much a book discussion, because you're formally talking about it amongst people. And so I thank you very much, Prabha and team, Nicola, for such good questions that helped us actually unpack a lot. And of course, my co-editor, Christa, who, due to her meticulousness and her vision, she said, whatever it is, we're going to get this out. So I thank her for her very very conscientious hard work and the synergy that she provided to see this through. Yeah. She saw through very crucial aspects of the publication.
And I thank you for the cooperation and the synergies. Yeah. Okay.
Thank you. Thank you so much.
Prabha, you could share the recording. Would you be able to? Okay, she's gone off. I'll request you for a record.
Yeah, Maya, I think it will be put up in a project channel, and I think you can get a copy of it. I'll just tell Prabha about it. Yeah. Okay. Thank you. Lovely meeting you all.